So you have your devices picked out. You know what you want to do. You know what you want to, what conditions you're going to be monitoring for, and you have the devices picked out to do them. The next part is making sure that the patient onboarding, consent, and enrollment is fully documented. It is amazing how much this is the issue in audits for programs. We about 70% of our customers the last year have been from other vendors that are coming into us. You'd be surprised how often there's issues with the consent documentation. You have to document knowing consent of the patient, and you have to make sure that you talk to the patient about the availability of the services, that there might be cost sharing, right, co-insurance. It's worthwhile to check to see if they have a secondary insurer or a joint enrolled Medicare Medicaid that might cover that, but you have to talk to the patient about it to make sure that there's set expectations. Also, that only one provider can bill for RPM service during the month, and then also that the patient can stop RPM service at any time. So CMS allows us to be verbal consent, but you have to document the details of the consent. I will say that there was an article posted by Nixon, a law firm, just the other day, that said some auditors are actually expecting written consent, even though it's super explicit that verbal consent is allowed. So I don't think that means that you should definitely get written consent, but boy, your verbal consent should be pretty clear. It shouldn't just say patient consented to program. It should say, I reviewed these things with the patient, they consented to the program. I will say, above and beyond the fact that this is a requirement, one real good way, a fast way to get sort of an audit and scrutiny is to have patients complaining that they were never enrolled and understood the program, right? It doesn't take that many patients to like call up Medicare and say, we got these EOBs, I don't understand where it's coming from. This is not, you know, something I agreed to raise scrutiny towards you. So on one hand, it's, you know, good to keep your nose clean and to have the documentation, the consent documented. At the same time, you don't want patients saying that they don't understand where this came from. The first thing that the OIG released last year, prior to the sort of the, hey, Medicare, we need to pay more attention to this, was an alert to seniors saying, hey, if you just get random phone calls saying it's RPM, that might not be legitimate. So setting expectations ahead of time with your patients and making sure they understand the program, what they're going to get out of it, what they're expected to do, when the device is going to come in, hugely, hugely important from both a compliance perspective, but also just from having a legitimate program that, you know, can be scaled out without a bunch of angry patients. And it's something that is failed to be, it's again, surprising how often this is not buttoned up, given that it really, once you get it, you know, the workflow, it's very repeatable and very easy to keep going. A few other things that we've seen sort of be issues in recent audits that we've heard of. First, medical necessity, right? So if you're in billing or even practice or medical field generally, you'll be familiar with reasonable and you know, necessary sort of the criteria that's required. So Medicare does not require an official order, right? There doesn't have to be like you do with you know, like a Holter or MCT study, things like that, because it's an ongoing care management service. It's not like I place the order, critical mass or report, or something comes back to me and I review the report. That's not RPM. So you don't need an order or a prescription or a requisition, right? But you need to have something analogous that's saying what conditions, what exacerbations, what acute conditions or chronic conditions or condition is being addressed with the RPM device, right? And that the provider feels that it's necessary given those conditions, and that it'll be, the data coming in will be, you know, used in the treatment of the patient. Doesn't have to be much, doesn't have to be a big signed requisition form, but you got to put something in. I will say that I think some of the auditors this year are confused on this because we're getting reports. We haven't had an audit of our customers yet. You get chart checks and things like that, but we haven't had sort of like a full audit. But the information we're getting from customers that are coming over to us and that we see on, you know, in sort of the industry, is that some auditors are saying that you need an order. I don't think that you need to go that far, but if you have something that sort of looks similar to it as far as a note in the chart saying why this is valuable, I think you're pretty covered. At the very least, you need that. A lot of folks aren't doing that even. And also you want to say in there, hey, the device is a blood pressure monitor because of their hypertension, and I am, during titration of the antihypertensives, I'm looking for XYZ. Then you have to make sure that the readings are centrally located, right? That there's they're being either actively monitored, there's someone looking at them, or there is a protocol that's been approved by the doctor for notifications that relate to the patient's condition and treatment plan. If blood pressure goes to, we do a lot of sort of dual, sort of two-step things too, where it's like, okay, blood pressure goes into the caution range 3 times, notify provider, right? Or in a row, notify provider. 2 times, notify the patient to take their blood pressure again. You want to build out protocols and escalation criteria so that it's clear that there is value coming in from these programs, right, from the data that you're getting, and there's feedback from the patient and back and forth with the doctor. And then obviously, you got to make sure that you document everything as far as the internet communications, the care management time logged. It's just, that's, normal rigor that's expected, for better or worse in the medical field, as far as how much notes and documentation we have to do.